Today we are discussing the topic neonatal jaundice and childhood immunizations. So we'll first be talking about neonatal jaundice. What is neonatal jaundice? Neonatal jaundice is just simply jaundice in the newborn. And what jaundice means is that there's a yellowish discoloration of the eyes and the skin and any other mucous membranes, as surfaces on the body. When that happens, we call it jaundice. Jaundice in the newborn is something that is of concern to most people, and most often mothers deliver, they are told that their babies have jaundice and they have a whole lot of concern. So what we want to address today is to let us know what jaundice is, what causes jaundice, why will my baby have jaundice, what causes jaundice, and when my baby has jaundice, what can I do, or what do I need to know about jaundice, and then the treatment options that are available when the baby has jaundice. So I've defined what jaundice is: yellowish discoloration of the skin or the sclera or other surfaces in the body. In a newborn, that is neonatal jaundice. It is something that occurs commonly in children, and we have, it is something that occurs commonly in children, and we actually have what we call two types of jaundice. So we have what we call physiological, or the word normal, what we call normal jaundice, which most babies will have. And we have what we call the pathological or abnormal jaundice, which usually requires treatment. Why will a baby have what we call normal jaundice? Babies are usually born with a very high red cell mass, so their PCV is higher. Their cells are actually, they break down more easily. And so when they leave the environment of the womb, the body has its way of bringing that down. The oxygen saturation outside is more than what they were experiencing in the womb. And so they start breaking down these cells, and they could have what we call some form of normal jaundice, which they have. I will make delineation between what normal and abnormal jaundice is later. Okay, so for the abnormal jaundice, it means that it's going beyond what we call normal. Whether something is causing the jaundice, or there are other factors available, whether in the mother or the baby, that is causing the jaundice. So what are the causes of abnormal jaundice? Most often, the causes of abnormal jaundice, the cause is not known. However, in instances where there is, some of the causes include what we call blood group incompatibilities. So when we have blood group incompatibilities, for example, a mother is rhesus negative and a baby is rhesus positive, and this mother has had a prior rhesus. Hello. Hello. This baby mother has had a previous rhesus positive. It sensitizes the mother such that when she has another rhesus positive, she could have developed antibodies that break down the red cells of the new baby, which leads to blood jaundice. Another cause of jaundice is what we call blood group incompatibility that causes jaundice. Is when a mother is blood group O and the baby is either blood group A, blood group B, or blood group A. In that instance, the mother has antibodies that could act against A, B, or AB. And so when the antibodies are fighting against the red cells of the baby, you could have the baby presenting with jaundice. And so because of these blood group incompatibilities, that's why blood group is an essential investigation in pregnancy. Some other things that could cause jaundice includes G6PD deficiency. This deficiency is just that the baby is deficient of the enzyme called G6PD. It occurs mostly in male babies. And when they have G6PD deficiency, when they are exposed to some things, it makes them start breaking down their red blood cells, and it produces jaundice. Another cause of jaundice is infection in the newborn. So when a neonate has an infection, it could result in the baby having jaundice. Another cause of jaundice is what we call breastfeeding jaundice. Breastfeeding jaundice just means that the baby is not having adequate intake of feed when you're breastfeeding. So when they don't have adequate intake, it could lead to an increase to jaundice. We also have what we call breast milk jaundice. Breast milk jaundice happens because some mothers have...
Good morning, Dr. Tomi.
Yeah.
Please, there's a lot of noise in the background. Can you please mute everyone else so we can hear you accurately? Because I can barely hear you. Please mute everyone so that we can hear you very clearly. Because there's a lot of background noise coming from people's mics.
Okay. Okay, is it better? Is it better now?
We are still here.
The noise is still there. The noise is still there.
We can still hear somebody discussing about coronavirus. Somebody is still discussing coronavirus at the background. Mute all people.
Okay, is it better now? Hello? Okay. So I was on the causes of, talking about the causes of jaundice, and I had mentioned blood group incompatibilities, among which is rhesus incompatibility and ABO incompatibility. I've mentioned G6PD deficiency as a cause of jaundice, where I said that the babies lack an enzyme called G6PD, which makes them to break down their red cells when they are exposed to some things. And so some of the things they could be exposed to that make the red cells to break down includes what we call naphthalene balls, which we commonly call camphor, and some sulfur materials. So we actually advise that mothers should not use camphor to keep their clothes in the wardrobe, because this could predispose the baby to jaundice if the baby has G6PD deficiency. I've mentioned neonatal sepsis, which is infection in the newborn, as a cause of jaundice. I've also mentioned breast milk jaundice. We have both breast milk jaundice and breastfeeding jaundice. Breast milk jaundice is due to an enzyme in the breast milk causing the breakdown of red blood cells, while breastfeeding jaundice is actually due to inadequate intake of breast milk. We have some other causes of jaundice, such as inborn errors of metabolism, which means that these babies lack either an enzyme that is involved in metabolism in one pathway or the other, which could make them to develop jaundice. Jaundice could be associated with things like hypothyroidism, when the thyroid levels in the child is low, and some syndromes such as Down syndrome and some others could have jaundice. So these are the major causes of jaundice. But like I said earlier, at times we just cannot find the reason for the jaundice. These causes are causes of what we call the abnormal or pathological jaundice. For the normal or physiologic jaundice, there should not be any baseline cause, And when we want to delineate these two, we delineate it based on one, when the jaundice started, what was the age at the onset when the jaundice was noticed? If jaundice comes within 24 to 36 hours of life, it starts before that, it is usually an abnormal jaundice. But if it starts later, most often it could be a normal jaundice. It may not be. The second thing we use to look at it is, how is the jaundice rising? Is it rising very fast, or is it just a slow climb? That will help us to delineate whether it is a normal jaundice or an abnormal jaundice. We also want to look at how high the jaundice goes. What is the level? For the normal jaundice, they don't usually exceed 12 milligram per DL, and this is usually about the 5th day of life. So what we are saying is that if we get 12 earlier, it is likely not a normal jaundice. So we look at the rate at which it is rising, and then we look at other factors in the baby that could have predisposed to jaundice to explain whether this jaundice is normal or it is an abnormal jaundice. Now, my baby has jaundice, what do I do? If a baby is jaundice, when you have your baby, the first thing we do when you have your baby is that your baby is observed every day to check whether the baby has jaundice or not. At the earliest sign that the baby has jaundice, most often you see us come into the room and we'll likely press your baby's nose down to check. That's called blanching. Or we want to look at the eyes if the eyes are opened, or we press any part of the skin. Ideally, when you do this, the skin should look like cream, white to cream, depending on the complexion of the baby. But a baby that has jaundice, when you blanch, it is looking yellow. If you have a baby that is leaving the eyes open, you're likely going to see that the white part of the eyes is looking yellow. Those are the things that helps us to identify jaundice. And we observe every newborn to be sure whether they have jaundice or not. Those are the first things we do to observe jaundice. Many babies may not exhibit jaundice before discharge, especially those that have vaginal delivery that go home early. And so, having done that in the hospital, we also advise mothers when they're at home to check, and if they notice jaundice anytime at home, they need to get back to the hospital. So the first way to see jaundice is observing the baby, checking the eyes, blanching the skin to see if there's any yellow staining of the skin. The second thing we do is, when we observe jaundice, we take a sample, a blood sample from the baby, and we check that baby to see the level of the jaundice. Now, why do we have to take the blood when we have seen the jaundice? Because we need to know the value of the level of the bilirubin. Bilirubin is that yellow pigment, that's the name for it. We need to know the level to decide whether we need to treat or we don't need to treat, whether it is going in line with a normal jaundice or it is an abnormal jaundice. And when we do that, we check the levels and we interpret these levels with the age of your baby and with any other factor present in the baby. Definitely, we are concerned, we want to have at the back of our minds the blood group of the mother. And if the mother is O or has a rhesus incompatibility, we'll be interested in knowing the blood group of the baby. So those are the first steps we do to identify jaundice. One, checking the baby all the time. If you have gone home, you also need to look out for it. And if you notice it, you need to report back to the hospital. And the second thing we do is we take a blood sample to have an idea of how high the jaundice is. When we have identified how high the jaundice is and there's a need to treat, what forms of treatment do we give for jaundice? And why do we have to actually treat jaundice? I know there are a lot of myths out there about jaundice. Some people will say if your baby is jaundice, just put under the sun. Some will say if you are exposed to early morning sun. Some people will say if your baby is jaundice, I've heard people giving things like pawpaw water and so many things. These are all myths around jaundice. But we all know that these things do not work. For example, putting your baby under early morning sun. Most of the babies this will work for are babies that have what we call normal jaundice, which will resolve on its own with or without treatment. But when the baby has abnormal jaundice, which we can only identify by having a blood test to know the level of the bilirubin, we don't advise early morning sun for those kind of babies. The treatments include one, putting the baby under what we call a phototherapy lamp. A phototherapy lamp is what has been structured to do, so let me just give a baseline on the history of the phototherapy lamp. When they found out that exposure to sun used to reduce jaundice, what science has done is to find out the wavelength of light that actually does that. And so the lights we are using to treat the jaundice are actually lights that have that wavelength that can help to reduce jaundice. So phototherapy is the first thing we do. What does phototherapy do? Oftentimes we have a baby on phototherapy and then we repeat the bilirubin and it is still rising. That's the jaundice level is still rising and parents are concerned. So I need us to understand what phototherapy does. Phototherapy does not actually reduce the level of jaundice in the blood. What phototherapy does is that it breaks down the jaundice pigments attached to the skin such that it can be excreted from the body. And so the more you break down, the more the pigment in the blood gets attached to the skin, and then you are passing it out. That is how it helps. So what do we have in jaundice? We have one, a rate of production of the jaundice. So jaundice is being produced, the pigment is being produced, something is producing it. You have a rate of production. Now the light is supposed to break down. So we have a rate of breakdown. As long as the rate of production of that pigment, bilirubin, is higher than the rate at which the light can break down the bilirubin, you are likely going to have the levels increasing. That is what is happening. So there's something causing the jaundice. It is an ongoing thing. It is producing the jaundice, but it is producing it at a higher rate than which the light can actually what? Break it down. You're going to have an increase in the level. It is nothing to worry about. That happens initially till the rate of production actually drops below the rate at which the light can break it down. However, in some babies, we have this rate of production still far higher than the rate at which the light can break it down. And at times we have the levels climbing up to as high as 20 milligrams or more. When we have it climbing up like this, then we need to have another form of treatment, which is what we call an exchange blood transfusion. What is an exchange blood transfusion? It just means that we are going to exchange the baby's blood. Somebody may want to ask, are you going to drain all my baby's blood? No, that's not what we do. I always explain exchange blood transfusion in this way. Imagine that you have a bottle of, I used to use Tree Top because it looks more like jaundice, but let's use a bottle of Ribena, the concentrated Ribena. And it's so concentrated, I want it to get lighter, which is what we are doing to the baby. We want it to become less concentrated. We want the level of jaundice to go down. So what we do is we empty that full bottle of Ribena a bit, and then we top it up with plain water that doesn't have any color. And we do that severally, such that at the end, the pigment, as the color of that Ribena in the bottle becomes what? Lighter. That is exactly the concept of exchange blood transfusion. So we take out small volumes of blood at a time, and we replace it with blood that does not have the pigment, bilirubin, which is what causes jaundice. And so we usually access the baby through the cord, putting a catheter inside one of the veins there, and then we use that to exchange the baby. Some babies actually, even with exchange transfusion, require more than one episode of exchange blood transfusion before we're able to get the bilirubin down. All we do during the course of treatment is that while the baby is on that phototherapy, we still monitor the level of jaundice. The rate at which we monitor the level of jaundice depends at the rate at which it is rising. So we may actually do bilirubin levels for some babies more than twice a day, 3-4 times because of the way it is going. And for some, we do it once a day, having looked at the rate of the rise, and we feel we can just do this on a daily basis. So the rate of rise, the level also determines the treatment. If it's in the range where we do not need to exchange, we put your baby under lights. And if it gets to a range where we need to exchange the baby's blood, we will do just that. You may want to ask, exchanging a baby's blood, are there no dangers? What we try to do is to ensure that the blood that is going to be used is appropriately screened. And when that is done, it reduces whatever risk. Also, the procedure is done in a sterile environment and not introducing infections. So that is the core treatment for jaundice. Now there are adjunctive treatments to jaundice, which means maybe there's a cause for the jaundice and we need to treat the cause of that cause so that the jaundice can actually come down well enough. One of the causes of jaundice that we could treat is neonatal sepsis, what you call neonatal infection or bacterial infection. Another myth is that when a baby has jaundice, people believe that it is cured by antibiotics. No. Antibiotics is only useful when a baby has jaundice because of an infection. That's a bacterial neonatal infection. And so antibiotics then become adjunct in the treatment of that jaundice. So the mainstay of treatment for jaundice is phototherapy and exchange blood transfusions when phototherapy is not controlling that level rapidly enough. And as an addendum, now we've spoken about all this. They'll put my baby under light. I just add my baby, oh, all I want to do is go home. Why are you keeping my baby in the hospital? Why are you keeping me in the hospital? We are doing that because of the possible and potential dangers that jaundice could cause, damage it could cause to the growing brain of a newborn. It is one of the commonest causes of what we call cerebral palsy because it causes brain damage. And then you have a child that may be deaf, may just not do well, have motor issues, not sitting when they are supposed to sit, poor neck control, and so many other things. And that is why we do not take jaundice lightly. That is why we may have to keep you in the hospital to be sure that your baby is out of danger. And that is what we have about jaundice. So, as for jaundice, we've talked about what jaundice is. We've talked about why my baby could have jaundice, the causes. We've talked about how we diagnose jaundice by both observing the baby and doing the blood test. We've talked about the treatment options for jaundice and when we need to apply it. And we've also talked about why we need to ensure that your child is out of danger before you leave the hospital as far as jaundice is concerned. Thank you. So I will take the second part and we'll take the questions together. Childhood immunizations. What are childhood immunizations? How do they come about? Why do they have to jab my child every time? Why do they have to give my child injections to make the child cry every time? Childhood immunizations are a series of immunizations that have been put together to address some common infectious diseases in childhood and early infancy in particular. So these are diseases that have been of public health interest that have contributed so much to child and infant mortality in previous times. And along the years, vaccines have been developed against these kind of illnesses that could protect the child against it. So what do we have in vaccination? We have what we call the vaccine itself, which is what will be given to the baby. And then we call the baby the host who reacts to the vaccine to get immunized. So it's when the host reacts to the vaccine, they produce antibodies that help to fight against such diseases. So we have different kinds of immunizations. We have what we call BCG. BCG is a short form of Bacillus calmette-guerin, and that is given usually for tuberculosis. It is given at birth. Also, we give hepatitis at birth. The hepatitis we give at birth is actually very important, especially for women who are hepatitis B positive. When the hepatitis B positive, we want to give that vaccine at birth so that it prevents the baby from having what? Hepatitis from the mother. There is something else we give along with hepatitis B, which is called immunoglobulin. hepatitis B immunoglobulin. That is actually like an antibody which is given. So that starts working immediately before the vaccine takes effect in the body. And when we give this to most mothers who are hepatitis B positive can actually breastfeed their babies without a risk of them having hepatitis B. So we also give oral polio at birth. This is to prevent the disease poliomyelitis. We have other vaccines. We have one that is usually called Penta. Penta is a pool of 5 vaccines. So it has diphtheria, the one for diphtheria, pertussis, tetanus, and then along with it now it has H influenza, and it also has hepatitis B, which is what is following on. So instead of your child having 5 jabs, the vaccines have been compressed into one single shot. Along with that, there are follow-on vaccines with polio at different ages. And then we have 2 forms of the vaccine schedule. We have what we call the National Program on Immunization Schedule, which just has most of the vaccines which the government provides. So the government provides for now the polio, they provide the hepatitis B, they provide the Penta, they provide the pneumococcal vaccine. They're supposed to be providing rotavirus vaccine, although that has not been regular. Measles, yellow fever. Vitamin A is not a vaccine, but it's a supplement that has been introduced into the vaccine program so that it can form a base for effective administration of vitamin A. So those are the common MPI vaccines, which the government sponsors and accounts for. But we have a whole lot of other vaccines, which while advocacy is on for it to be included in the National Program for Immunization, is available by private pharmaceutical companies, which your child can have. So we have things like typhoid vaccines, we have things like meningococcal has also been put in the MPI. We have the typhoid vaccines, we have the MMR, we have chickenpox vaccines. So there are many other vaccines, hepatitis A. There are a whole lot of vaccine preventable diseases. So you will do well to oblige your child to have not just the national program on immunization vaccines, but also those that the child are supposed to have, which you may have to pay for. But vaccines does actually keep diseases away. So the purpose of immunizing your child is to ensure that the child develops enough immunity to fight off all these childhood killer diseases, which could actually maim a child or cause issues for a child. Now, having talked about the vaccine, I will just infuse that the first immunization a baby has is the immunization, the immunity the baby gets from the mother. And so there are vaccines that have been advocated now in pregnancy, such as the pneumococcal vaccine to prevent actually infection in the neonatal period. It's advocated that mothers have a shot of some of these vaccines to actually help their babies have immunity in the neonatal period while they start their own vaccinations so that they can develop their own immunity. So vaccines are given to hosts, and when given to hosts, the host mounts a response producing antibodies which stay in the body so that when the diseases that those vaccines are given for comes, the antibody actually fights off the diseases. Okay, I've been advised to have vaccines. Are there side effects of vaccines? Are there side effects when my child is given many vaccines at once? Most of these vaccines have undergone trials. Side effects from them are minimal. You could have some giving fever. You could have some giving redness and pain at the area where it is given. But some do actually give some more serious issues, especially some babies convulse after their DPT. And so what happens is that we use another type of DPT for them that is not an activated type. So all these things are put into consideration. And also when your child is given a vaccine, we advise that if you notice anything in the child, please present to the hospital. It may or may not be associated with the vaccine. It may just be something that is just incidental. So you have a child that already wants to develop malaria, coming for a vaccine and having a fever. We don't always want to assume that it's just the vaccine. We want to be sure that it's not something more serious with that child. So in summary for vaccines, immunization, childhood immunizations are a series of vaccinations that are given to babies at different points and ages in their lives. Some are single doses, some are multiple doses, and you'll be given appointments for it to ensure that the baby actually develops enough immunity to withhold and withstand the childhood killer diseases and infections that may want to attack them. Thank you very much. I will leave it open now for questions. Hello? So I will just quickly address, I have some questions on the chat, and I will be addressing these questions one after the other. Okay, somebody said, apologies, I couldn't get into the classroom from the beginning. What causes jaundice in a child, and is it preventable in utero? So we listed some causes of jaundice. We talked about blood group incompatibilities, infections. We talked about G6PD deficiency and so on. Okay, I'm sure this will be on record, so you can actually go through it later. Is it preventable in utero? Yes, some forms of jaundice are preventable in utero, especially when it comes to rhesus incompatibility. So if a woman has had a previous pregnancy, a rhesus negative woman has had a previous pregnancy that is rhesus positive, the possibility of being sensitized is there. Now, they are usually given Rogam after delivery so that they do not get sensitized. But in case there has been a sensitization, what is done in utero is that you are monitored for that, the level of the antibodies, the anti-D antibodies that the mother has, and your baby is also monitored for any signs or symptoms that there is actually a rhesus isoimmunization going on. And if that is there, there are things that are done. Most of these babies actually have to be delivered earlier because rhesus isoimmunization is actually associated with increased fetal loss. So that can be done in utero, monitoring to check for sensitization, giving additional doses of Rogam during pregnancy, that can be done in utero. So I think those are the questions on the thread. I think I will unmute now for people that want to ask questions. Thank you. Okay, please, I've allowed people to unmute themselves, so if they have questions, they can ask the questions. Thank you.
Okay, doctor, good morning.
Please, we have a question.
My name is Bankole. Can I go ahead? Hello?
Yes, sir.
Yes, this question.
Yes, you can.
Okay, I've had people ask me this question over and again, and I think I better get clarification so that others can benefit from it. It is possible for a child to come down with an infection for which the child has been properly immunized. For example, is it possible for a child who has had measles vaccination to also come down again with measles? Is it possible for a child who has been properly immunized against polio to have polio? And all those questions have been asked before. And I think it's good that we clarify that now.
Okay. So is it possible for a child who has had an immunization to come down with the disease again? Yes, it is possible. It is possible because what we are doing when we give a vaccine is that we are introducing a vaccine, an antigen, into the child's body. After introducing that vaccine into the body, we expect that the child, who is the host, we call them the host, mounts a response sufficient enough to prevent them from having the disease. So we have what we call host factors. For some reason, some children do not mount up enough response when they are given the vaccine. That is one issue. The second issue is the quality of the vaccine that has been given. And so we advocate that you watch out for where you take your vaccines. Vaccines are usually kept in what we call a cold chain system. Most of them need to be refrigerated. And when there are fluctuations in temperature and so many things, it could affect the quality of the vaccine that is being given. So if the quality of the vaccine being given has been affected by anything, it's possible that the vaccine given is not of good quality to make the host mount a response. That is one. And the second thing which I mentioned earlier is that there are some reasons why some children or individuals who are hosts are given vaccines and they do not mount enough response. Now, let me use an example for BCG. BCG is usually given to protect against severe forms of tuberculosis. Listen to me, severe forms of tuberculosis. So BCG does not actually protect fully against tuberculosis, but it prevents the person that is infected from coming down with severe forms of tuberculosis. When BCG is given, it is usually given on the left upper deltoid now. We expect that the host mounts a response. The response includes the area having what looks like a swelling, forming what looks like a boil, discharging some pus, healing and forming a scar. If a child is given BCG and we don't see that reaction, we are bothered. We are bothered that as this child mounted a response to this vaccine. And so what we usually do in such circumstances is to do a Mantle Test to see whether the child actually reacted or not. We interpret the Mantle Test, and if we see that there was no reaction, we actually repeat these vaccines, the BCG. Now, because BCG gives us a visible reaction, we're able to do that effectively. However, for other vaccines, what is done in some clients is that they actually, after some time, monitor the antibody levels for these individuals to be sure that they actually mounted a response. And if they feel it's not adequate, then the vaccines are repeated. But we do not have those facilities here. But in all of this, what we need to ensure is that wherever our children are taking the vaccines from, we need to be sure that it's a place where we can vouch for the fact that they have kept the cold chain system all through the period of transportation of that vaccine down to the facility and when they are administering the vaccine. So yes, it is possible. We've had children who have had measles vaccine coming down with measles. What we notice in most of them is that the severity of the illness is usually less. And so for something like measles, it's been advocated now that you don't just have a single dose of vaccine. They usually have their vaccine, measles vaccine at 9 months. And then when they take the MMR, MMR also has measles in it. It forms the second dose, which boosts the immunity. And then making sure you complete the dose of whatever vaccine is given is very important. If it's 3 doses, please make sure you take the 3 doses. If it's 2 doses, make sure you take the 2 doses. Because what they have done to arrive at the number of doses is that they've realized that you need this amount of doses to mount sufficient immune response to that particular disease. Now, for some of the diseases, things like diphtheria, pertussis, tetanus, we advocate for booster doses later on in life because studies have shown that as they grow, some of them, the antibody level drops. So there's an advocacy that booster doses should be given. So for DPT, after they've had it in the initial 10 weeks, 6, 10, 14 weeks, at 1.5 years, we expect them to have a booster. It's not in the MPI yet, but we expect them to have a booster, and we expect them to have it also at 5 years and around 10 years of age. By the time they do this, it helps the immunity, because we are seeing that we are having those diseases coming down in older children. So we are advocating that booster doses should be received as a matter of compulsion, to ensure that children don't come down with these diseases when their antibody levels drop. I hope I've answered your question.
Thank you very much. You have. Another question, which I've been asked over and again, and I think it's good for you. What's the role of vaccination against cervical cancer in children? Is there a place for cervical cancer, especially in a female child? Okay.
So the role of vaccination for cervical cancer in a female child. Cervical cancer is a disease that has been found to be associated. It's almost always associated with what we call human papillomavirus infection. And because of this, vaccines have been developed against the human papillomavirus infection. Now, the vaccines that have been developed are against, there are different strains of human papillomavirus infection. So the vaccines that have been developed are against the common strains, the strains that are commonly associated with cervical cancer. Now, what is the mode of transmission? It's a sexually transmitted infection. That's the human papillomavirus. So the advocacy that you give this to younger girls, aged between 9 to 13, is because we are trying to ensure that we give these vaccines to female children ever before the age of sexual activity. Now, some people may say 13, I don't expect my child to be sexually active, but we are not with them all the time. So we want to give them these vaccines to ensure that before a child is sexually active, they already take the vaccine. So it protects them against those common strains that causes cervical cancer. However, if your child has taken that, when they grow later in life, it does not obliterate, that it does not stop the fact that they need to have their periodic screening when they go later in life. So the preventive measure for cervical cancer is 1, childhood immunization between 9 and 13 years. They are to have 2 doses, the first dose, and then 6 months after the second dose. And also, when they get to the reproductive age, once they are sexually active, we advocate from around age 30 up, they need to have their periodic pap smears, which are tests taken to look at the cells in the cervix to know whether they are okay or whether there is any abnormality there. So the two works hand in hand, the vaccination to ensure that we vaccinate before exposure. Because when you are vaccinating after exposure, the infection is already there, okay? And what actually causes the cancer is when you have, for most people, one way or the other, they clear the infection. But when the infection is persistent, then it is associated with a higher risk of developing invasive cervical cancer, which the screening also tries to prevent. Because when it is caught early, then treatment can be started early before it gets to the invasive stage of cancer. I hope I've answered that question too.
Thank you very much.
Yes, sir. Any other questions, please?
Yes, good morning, doctor. I have a question, please.
Okay.
Yeah, my question is about typhoid vaccine.
Okay.
So if child has typhoid vaccine, does it mean that the child will never have typhoid? Or does it mean that the child might have it, but maybe like you say, the symptoms manifested might be less than normal?
Okay, so for typhoid vaccine is a vaccine that does not have, number one, the one primary thing is it does not have a lifelong protection. It's a vaccine that needs to be taken repeatedly, like every 3 years. So it doesn't confer a long-term protection, 1. 2, they were developed especially in areas where they usually have what we call Salmonella outbreaks. Okay, that's the second thing. The third thing is that Salmonella has different strains. There are different strains, okay? It's like developing different types. So at times when you develop a vaccine against a strain, with mutations and all, changes in the bacteria and all, the vaccines you are giving may not be actually appropriate for the strains those vaccines have been developed against, okay? So primarily, now back to the basics. What is the primary way of prevention of typhoid? It is a waterborne disease associated with contaminations of food, contamination of water and all. So we always advocate on the public health view that we need to take care of those ones. The vaccine is actually supposed to be what? An addition. And when it comes to in areas where you have issues of cost and all, we still want to advocate those other measures more than typhoid vaccination. But if you have the means to take it every 3 years, why not? It will confer some protection, but it may not protect against every strain of the typhoid, the Salmonella typhoid that are available, that are around. So please, precautions still needs to be taken when it comes to hygiene, food hygiene, water hygiene. Okay. Does that answer your question?
Yes, yes. Another question. There's this belief amongst mothers that, especially those initial immunization, I think the one that comes at 6 weeks or thereabouts, that the children or the child can be given paracetamol before the immunization, that it would reduce the effects, not the effect of the immunization, but the effect on the child, as it were. So there's always this debate about the paracetamol reducing the effects of the vaccine on the child and not just the symptoms that might manifest on the child. I don't know if you understand my question.
Okay.
So basically what I'm asking is it okay to give a child paracetamol before vaccination, or do you just allow the child to go through the effects of the vaccine and then you give paracetamol after?
Okay, what's the role of paracetamol? One, if we prevent, is a pain reliever, is an analgesic, and two, is an antipyretic. That's for fever and for pain. Okay? Now, the child does not have a fever before the immunization, and the child is not having pain before the immunization. So there's really no point that you must give before the immunization. But when the child has the immunization, it takes some time for that inflammation and pain to be there. So you could actually just give the paracetamol after. Now, the paracetamol can be given up to 4 hourly, 6 hourly, 8 hourly, depending on how it is. So if you're giving it ahead, well, the effect might even wear out before the child needs it. You will still need to repeat it after. So what I would just say is, get your immunization shot. If the child is irritable or having pain, give your paracetamol. If the child has a fever, give the paracetamol. It helps because those are the two main reactions when it comes to DPT or Penta now. The pain and crankiness, and then some of them develop a fever. So paracetamol comes in handy, but there's no law that says you must give it before the vaccine. You can actually give it after the vaccine shots.
Thank you. Last question, please. It's about rotavirus vaccine.
Okay.
Yes. So I gave it to my first child, and in fact, it was a nightmare. I think I eventually regretted it. I don't know, because it affected his stooling. It affected basically everything, and the vaccine even came expensive. So at a point, my husband and I were even asking, what really was the importance of this vaccine? Maybe we should have just, ignored it. And so I really want to know from your professional advice, is it something that, going forward we should do, or just,
Rotavirus vaccine is to prevent against the commonest cause of diarrhea in infants, which is rotavirus. It's the commonest cause of acute watery diarrhea in infants, and it could be very, very profuse, okay? It could be very profuse. Some of them dehydrated and all that. So we advocate that they take it. Now, if your child has had that reaction, I don't have the details of the reaction. And like I said, that there are times that symptoms after a vaccine are incidental, like a coincidence, which means that if this child does not have the vaccine, You understand me? This thing would have happened. It just happened around the time the child had the vaccine. And yes, there might be some things that are due to the vaccine. This is the first time I'm getting that feedback that a child had rotavirus vaccine and had issues involved. But we always advocate that, please, if you notice anything after your child has had a vaccine, you should report it. We have what we call adverse events following immunization. It's something that must be reported. Because when we are giving all these vaccines, we want to know if there are any untoward effects in any child that needs to be addressed. So, but I don't know the circumstances around and all. The child could have had diarrhea around that time or anything, even without the rotavirus. But it is not a common, in fact, like I said, that's the first time I'm getting that feedback on rotavirus vaccine. So we can't, because of that, say that a vaccine that is safe and has been effective should not be given. Like I said, several studies are done before these things are rolled out, okay? And then we classify the side effects as common, uncommon, rare, and all that. It's not something that is a common thing, it's a rare thing. And so we can't say because of that they shouldn't take vaccines. And the caveat is that the baby might have had all those symptoms with or without having taken the vaccine. So we need to be sure what the association is between the vaccine and the illness the baby had. Okay?
Yeah. Well, we actually took him to hospital because, you know, it was getting out of hand. It was just basically like the symptoms of the rotavirus disease itself. So
Okay.
the doctor told us then, I didn't have him in mother and child though. The doctor told us then that it was just symptoms of the vaccine that it was going to wear off. So,
Yeah,
but by the time he had his second shot, there was no drama with the second shot. It was just the first shot. It was really
good. So,
you know, so but by the
being
second
that he
shot,
didn't have any issues with the second shot, it could just be that it was a coincidence, one. Two, it could be that the first one, his body reacted that way. Because, you know, some of these vaccines, the way vaccines are produced, they actually use protein from the actual diseases. There's a way they do it to get to the vaccine. So at some time, some of those things actually give a disease-like reaction. You understand? A disease-like reaction. And he may not have it the second time because if he's gone through that reaction, he's developed antibodies. So the second one was more tolerable. So it's a possibility.
Okay. Thank you, doctor.
Okay. Matt, there are 3 questions in the chat box.
Okay.
Please come.
Are there meals to take to prevent your baby from having jaundice? That's meals, food you can take. No, there's no meal that you can take to prevent your baby from having jaundice. Because all the things that we have said about jaundice, none is pertaining to the fact, none pertains to the fact that you ate anything that will cause the jaundice. But the things that you should keep up, your clothing, we've talked about camphor, naphthalene balls. Please, no mother should store their clothing or the baby clothing because you used it the last time, you washed it, you don't want it. If at all you even did that, before you have the new baby, you need to wash out the old house, wash out all the clothes, make sure they are free of naphthalene balls. But it doesn't have anything to do with a meal. Somebody says, I've been having severe pains in my ribs, thighs, ankle, and waist. Please, I want to know what could be the cause. I'm just 17 weeks gone. So I'm going to mute myself and allow any of the obstetricians online to talk.
Sorry, please, what's the question again?
The question is, I've been having severe pains in my ribs, thighs, ankle, and waist. Please, I want to know what could be the cause because I'm just 17 weeks gone.
I think the advice would be that the person should go to hospital. Let the doctor find out what is wrong.
Good, thank you.
It is not like right to answer that type of question when you have not seen the patient. It could be dangerous. Please go to the hospital.
So please go to the hospital. You have read it from your obstetrician. So that you say it's a pediatrician that said go to the hospital. Okay. Any other question?
Yes, please, I have a question myself.
Okay.
Thank you for the lecture. Now, you're talking about breast milk jaundice.
Yes.
Please, I just want you to explain to the mothers that this does not mean that breast milk causes jaundice, so that they won't run away from breastfeeding their mothers. Please, if you can talk to us,
Okay.
especially those who connected late.
Okay. So, yes, we do have what we call breast milk jaundice. I mentioned two things about jaundice and breast milk. We have breastfeeding jaundice, which is due to inadequate intake. Then we have the breast milk jaundice because some mothers have an enzyme in their breast milk that causes that. Now, the thing with breast milk jaundice is that it doesn't usually cause a very severe form of jaundice. It doesn't start that early. It will likely resolve itself. It will make jaundice to be a bit more prolonged, but it will not cause a severe form of jaundice, and it will usually resolve. We do not stop breastfeeding because of this. If at all we want to stop breastfeeding, it may be because we feel the level is a bit up and we want to bring it down a bit. So you are asked to maybe reduce the quantity of breast milk you are giving for like 48 to 2 hours and thereafter resume your breastfeeding. Once we do that, the levels do not usually rise as high as before. So when a baby has breast milk jaundice, it is not an indication to say you do not want to breastfeed your baby. It's not an indication to stop breastfeeding. The only caveat for stopping breastfeeding is just a brief moment, if the levels are quite a bit high, to ensure that we drop that level of jaundice. And usually when you start the breastfeeding after 48 to 72 hours, the level does not rise to the previous level. So please, if that happens, please breastfeed your baby. See a doctor. One thing with jaundice is that don't assume. If you can't assume at home breast milk jaundice. You can't assume at home it is normal jaundice. You can't assume at home, oh, it is this. The levels must be done. The doctor or pediatrician needs to take a detailed history, look at the cause of the jaundice and other things before they can give you the advice that you need for your baby. But please don't stop breastfeeding your baby because your baby has jaundice. There is no contraindication to breastfeeding in neonatal jaundice. Thank you.
Please, I just want to add also that it is not a common thing. It's very, very uncommon.
Yeah.
And all the other causes must be excluded before you can say it's breast milk, so that people will not assume. Thank you very much.
Okay. Good morning. I can't hear you. I can't hear you.
Okay. Yeah. Can you hear me now?
Yes, I can.
Okay. I thought I enjoyed it a bit late.
Huh?
Hello?
We can't hear you clearly. You could help by typing your question and sending it to the chat.
Okay.
Okay. Okay. Any other question?
The Bluetooth device is ready to pair.
Okay. Can you hear me now?
Yes, I can.
Okay. I said I joined in a bit late, but I still want to ask if you can still answer this. That what is the major difference now between the normal jaundice and the breast milk jaundice, and how do you know the difference? Do you understand? And how do you know? Okay, this is normal jaundice, or this is the symptoms of the normal jaundice, or the symptoms of the one caused by breast milk?
Okay, rather than delineating between normal jaundice and breast milk jaundice, I will say delineating between normal jaundice and abnormal jaundice.
Okay.
Okay? Abnormal jaundice is any jaundice. I said that we interpret jaundice based on the age at which it was noticed. That's the age it started. We identify it by the rate at which it rises, and then the highest level it gets to, and how long it takes to resolve. Okay? So at the initial time when jaundice starts, the only thing we can say is, oh, This jaundice started within 24 hours. It's likely an abnormal jaundice. This jaundice started after 24 hours. It's possible it's a normal jaundice. Okay, let's do the test. Then we do the test. And then the test comes back as 12, let me give an example, 12 milligram per DL in 24 hours or 36 hours of life, which is what we are saying should actually be, is likely a normal jaundice. Now, the level at that 36 hours of life is already telling me, no, this jaundice is not a normal jaundice. So it's not just one criteria we use. We use the criteria of when it started. We use the criteria of how high it is at a particular age, at the age where we are doing the test. We use the criteria of how high it goes eventually. Normal jaundice will not pass 12 milligrams. It will reach 12 milligrams before the 5th day of life, and it will not pass it, okay? Abnormal jaundice will go beyond that, either earlier or later. Then we use the look how it is resolving. Then we also look at risk factors. So if I have a baby with ABO setting now, I want to look at the rate of rise. Is it rising more than 5 milligrams per day? If it's doing that in 24 hours, then it's definitely abnormal jaundice. If it's rising like 2 per day, it's likely a normal jaundice. So there's a whole lot of things we look at. And so it is not for the mother to say, this is a normal jaundice or this is an abnormal jaundice. It is for the pediatrician or doctor to look at the values, look at the age of the child, look out for risk factors, and interpret for each baby around the values, the age, and all these things that we have said, okay? So your whole role as a mother is, I've been discharged from the hospital. My baby didn't have jaundice. When I get home, I must look out for jaundice. I still emphasize, jaundice can start at home. So don't think that when I'm discharged, I'm given the care, it means my baby cannot have jaundice. Mothers learn, if anybody and says, this baby looks yellow, it is enough for you to get back to the hospital and have a jaundice test. Please do not interpret jaundice yourself. You interpret it with a whole lot of things.
Dr. Narawaju, you are disturbing us. Dr. Narawaju, you are disturbing us. Please mute.
Okay, good morning, madam. I didn't really see a change after that. Good morning. Good morning, ma. I noticed that the smell of the urine.
We can hardly hear you.
Somebody is talking.
So it was
Hello.
Good morning, madam. Sometimes I could feel rumbling, like my pelvic area. I have a question. I want my baby's my baby's current.
Hello, Dr. Larewaju, you need to mute.
Please mute, Dr. Larewaju, you are disturbing us.
I want to use my baby as to ask the question. It's progress. Can you hear me? Okay. When I gave birth to him, last week Monday, and he came out with a very clear white eye, but he didn't feed until like the second day. So before we were discharged on Wednesday, I started noticing that his eyes were turning yellow. So before they discharged us, they did the SB test, and it came out it came out 6.6.
Okay.
So we're discharged. So by Saturday that I took him for immunization, I did the test again, and he went to 13.3.
Okay. So you delivered which day? Sorry.
I delivered 7th.
7th. That's a Monday.
Yes.
Okay. Then on Saturday it was what?
It was 13. 13.3.
Okay.
So I took him back home, but I was at the hospital yesterday again. I ran another test, and it came as 8.2.
8.2. Okay.
Yeah. So I'm supposed to do his circumcision, but I could not do it because of that. So I was asked to take him back until he goes down. So I was advised to breastfeed him and. Hello? Oh, I can't hear you. Breaking. Hello?
We can't hear you, ma. It's breaking.
Hello?
Yeah.
Hello?
So, that was the 6th day of life. And your baby said, hello?
We can't hear you. You're breaking.
Hello, can you hear me now?
We can't hear you, ma.
Hello, can you hear me now?
Yes, yes.
Hello, hello.
Yes.
Hello, can you hear me now?
Yes, ma.
Hello?
Yes,
Yes,
I can
we
hear
can.
you now.
Okay, sorry, I think the network.
hear you.
Okay. So your baby had jaundice on the 3rd day of life, which was Wednesday. It was 6. That 3rd day of life, that value on the 3rd day of life was not anything to be suspicious about. It looked like a normal jaundice. And that was why you were discharged. Coming back on Saturday, which was the 6th day of life, the jaundice agreed to 13.3. Now, because it was the 6th day of life, I'm sure that's why they asked you to just go and let's see how it goes and come back for a repeat test. Usually, normal jaundice will not exceed 12 milligram per DL by 5th day of life. Some slightly do, but if you look at the value on Wednesday, which was the 3rd day of life, it was 6 point something. If you look at the value on that day, it was 13 point something. It has risen by about 7 in 3 days, which means the rate of rise is about 2 point something milligram per DL per day, okay? So it wasn't a rapidly rising jaundice, and that's why you were asked to go come back for another test after the 6th day. In some clients for the 13.3, you may be kept just for observation and to see it. And then we also have a chart that used to plot jaundice that shows us low risk, intermediate risk, and high risk. So if they put you on that chart and you fall in low risk, at that age, you might be asked to go and come back for a repeat. By the time you came back for a repeat, the level had dropped to 8, which shows that it was resolving anyway. And that's why nothing was done.
Okay.
So a jaundice that started as a normal distance, by at that age, we interpreted it as a normal jaundice. Yes, it rose to 13.3, but it was a low risk level at that age. We did not need an admission. And then when it was followed up subsequently, it was already clearing. So that's the history of your baby's jaundice.
All right. Thank you, ma.
Okay.
Thank you, ma.
You're welcome. Any other question? Hello? Hello?
Yes,
Any
ma.
other question?
Yes, ma. I just wanted to ask that. Why do babies, why do they have jaundice? And how do they get jaundice from the womb? Is it from what the mother has said?
No.
Hello, ma. Hello, ma. Sorry, let me add to that question, please, so that you answer together, please. I want to ask that is there anything a mother is doing that can cause jaundice to that child? So we want to know what's the cause,
Okay.
the main.
So what are the things that a mother can do to prevent jaundice?
Yes.
What she's eating is not part of it.
Okay.
But let's start from the things that she can do. 1, book for antenatal on time. 2, have your antenatal screening test done. Knowing your blood group is very, very important. 3, give your doctor the history of previous pregnancies. 4, if you are a rhesus negative mother, make sure that you had your ROGAM in the pregnancy. ROGAM is what is called, it is given to prevent sensitization for the D blood group antigen. So make sure that you have that. 5, when you have your baby, breastfeed your baby effectively. 6, when you have your baby, ensure your hand hygiene and reduce the risk of infection. 7, if you are pregnant, you are term, and suddenly you rupture your membranes, please get to the hospital on time, because when the rupture of membranes is prolonged, it predisposes to infection, which can cause jaundice. Another thing that causes jaundice is prematurity. So if your baby is preterm, they are most likely going to have jaundice, okay? I forgot to mention that before. But these are the things you can do. Antenatal, make sure it is there. That's why they screen. During antenatal, if you give the history that you've had a previous baby or a previous pregnancy, whether the pregnancy was a viable pregnancy or not. If you are rhesus negative, you've had a previous pregnancy, we want to be sure you had ROGAM. They want to do tests to be sure that if you are sensitized or not, the antibody titer in pregnancy. And when they do all these things and they find out you are not sensitized, fine. If you are sensitized, they need to monitor that baby effectively. Now, somebody said jaundice developing in the womb. No, jaundice does not develop in the womb. The reason jaundice does not develop in the womb is this. Even if there was that risk, even for those that have been sensitized, your kidneys, your liver, your kidneys, everything is working for that baby. So there's a way you tend to clear, even if it's developing from immunization, you tend to clear it. If our babies that are born to rhesus negative mothers who are sensitized, when they come out are not jaundiced. They only have what you call pallor. The only thing you might see is that their blood level is very low. They are looking pale because your system has been helping to clear this jaundice. That's the one that usually happens inside anyway. And when they come out, that's when you start seeing the jaundice, because now they have to clear it effectively themselves. It is not what you eat that causes jaundice. It is caused by incompatibilities in blood group, some which can be prevented, like taking the ROGAM, caused by neonatal infections, caused by prematurity, caused by inadequate feeding or inadequate breastfeeding. We said the other one is enzyme in breast milk, which is very rare. I mentioned G6PD deficiency, and I said, please don't use camphor on your clothes. Or if grandma is coming, tell her to wash her clothes free of camphor if she uses it. No camphor near your babies, because it can make their red cells to break down if they are G6PD deficient. I've talked about your hand hygiene to prevent infection. So anything you can do to prevent infection, such as during your delivery, hygiene, if you have any discharge before delivery, please let the doctors know so that you are treated before your baby passes through that pathway. So those are the things you can do that can help to reduce the risk of jaundice. Okay? But it's not about what you eat or what you didn't eat. Am I clear?
Okay, ma. Thank you, ma. Yes.
Any other question?
Okay. Hello. Hello.
Hello.
Good morning.
Hello.
Hello.
Good morning.
Good morning. Sorry. Okay.
Good morning.
Is it
Good
right?
morning. I can...
Okay. Is it right for us to say now that malaria in pregnancy does not cause jaundice? Hello. Hello.
Malaria
in pregnancy, yes.
Malaria in
There's always this, yes.
Not listed. People have that conception that jaundice is caused by malaria in pregnancy. No.
Yes.
Malaria in pregnancy can cause other things in your baby. It may make the baby to have a low birth weight. It may make the baby, when they come out, also to have congenital malaria and be sick. But it's not the cause of jaundice. In fact, it's not. If at all it is anywhere, it is far. Malaria in itself will cause jaundice when it breaks down red cells. But it's not a common thing in neonates. And so when we are talking about causes of jaundice, is this thing. All the treatment for malaria and all is, one, to make sure that you are not having a baby with low birth weight. You as a mother, you are not having anemia, low blood levels and all that. And then when the babies are born, they don't have clinical malaria. That is why you are giving the intermittent treatment during pregnancy. Yeah.
Okay. Thank you.
Okay, ma. This another question. My mom-in-law, they said something about ampiclos. in association with the clearing of jaundice.
Okay.
And I told them clearly that they did not give me any drug from the hospital, so I don't think I would maybe buy into the idea.
Yeah.
I just want to clear that.
We're right not to buy into the idea. The only time that antibiotics, and it's not even ampiclox drops. Ampiclox drops when it is newborn infection. Okay, if a baby has neonatal sepsis, that's a neonatal infection that needs antibiotics. I want to tell you that ampiclox drops is useless because the dose is not going to do anything. In fact, it will make things worse if the baby has infection, because you are just going to be making the infection fester with a low dose antibiotics that is not effective. If at all a baby has jaundice, which is caused by a neonatal sepsis or infection, what we do is that we give those babies intravenous antibiotics, okay? And we admit them and we give it to them. And while we are giving them the antibiotics, we are also putting them under light. So what treats the jaundice is the light. What helps to stop the production of the jaundice, which is being caused by infection in this case, is the antibiotics. But it is not all neonatal jaundice that is caused by infection. So it is not all babies with jaundice that must have an antibiotic. Am I clear?
Yes, ma'am. What about Abidec?
Abidec is a multivitamin. If a mother is feeding well and you have a good quality of breast milk, your babies do not need drugs. But oftentimes, when mothers-in-law and daughters-in-law, the pressure is more, they are clashing, the pediatrician, we often say, okay, give Abidec or Afravite or whatever. That is just a multivitamin, it's a supplement, okay? But in itself, it's not as if it is compulsory.
Okay.
But we are coming from a generation who is used to having a bowl of drugs for a baby when the baby comes out. So a generation we are telling you how your child needs to grow is to be fed and give an enabling environment. So when who comes to show, most of us will tell you, okay, let's give Abidec. But if you're a mother, you are feeding very well, you're breastfeeding your child, you have good quality of breast milk, the supplements and all that are there, then it's very good for your baby to just breastfeed. Okay? But if who comes to show, we always tell mothers to compromise on the Abidec.
All right.
So that they have the feeling that they are giving something, that's all.
Thank you.
Okay. Okay. Last question. Any other question? Okay, thank you, everybody.
Thank you very much, Doctor.
Thank you for coming online for this antenatal session. I do hope that for the pregnant mothers, we wish you safe delivery. We wish you a jaundice-free neonatal period, but if jaundice does happen, I think you should be reassured that it will be taken care of, and when it is taken care of, there will be no issues. Thank you very much for coming on board. Ensure that your babies have their immunization as at when due. I wish you all a pleasant delivery. Thank you and have a great day.
Thank you very much. Thank you.
Thank you very much.
Thank you, Doctor.
Thank you.